Pediatric Dentistry Clinic. Okay. So basically today we will be actually covering the principles of tooth cavity preparations. Okay. So we covered the materials last week. I hope all of you understood what was taken last week. So today we'll be basically covering the principles of cavity preparation, which you have already learned in your resto sessions. But there is slight modification when we speak with regard to primary tooth cavity preparation. Okay. So, any doubts, please stop me in between or type it in the chat box. I'm more than happy to actually repeat. Okay. So, coming to today's lecture's objectives. So, we'll be dealing with as to why we are actually restoring the primary tooth or the reasons for restoring a primary tooth. Okay. And you, by the end of this session, you will be having a thorough knowledge on the primary tooth cavity preparation. Okay. Yeah. So before going into the details, we'll be basically discussing with regard to certain terminologies. Okay. So you all know what a cavity is. Cavity is anything in which there is a breach in the surface of the tooth. So you can tell in simple words a break in the continuity of both enamel and dentin, resulting from the pathological process of dental caries. So I'm sure all of you know what a cavity is. Okay. What is a cavity preparation then? It is a mechanical alteration of a defective, injured, or a diseased tooth, which will help us to give a best restorative material, or it will enable the tooth to receive a restorative material, which will in turn re-establish a healthy state of tooth, including the normal form, function, as well as the aesthetics. Okay, so that is the ideology of cavity preparation, or why we are actually preparing a cavity. So we want to return the tooth to its normal form, function, as well as aesthetics. Okay. So we have different materials which will actually enable us to do so, and certain materials will not fulfill certain criteria. For example, silver amalgam won't fulfill the criteria of the aesthetics. Okay. Whereas your composite will do that purpose. Okay. So it depends on the materials which you'll be using in our cavity preparation as well. Okay. So what is a cavity form? It is a form in which all the defects are removed, which gives necessary protection to the pulp, which locates the margins of restoration as conservatively as possible to form the cavity, so that under the force of mastication, the tooth or restoration or both will not fracture, or the restoration will not be displaced. So this is basically your resistance form as well as your retention form. I'm sure all of you might have learned the primary retention form, the resistance form, your convenience form. So basically that is coming in this definition. Okay. And it also allows for the aesthetics as well as the functional placement of the restorative material. Now coming to the objectives. Okay, so while we are preparing a cavity, or while we are actually doing a restoration, what is the primary objective? While we are actually preparing a cavity, we will first look to remove all the disease process, right? So we are trying to remove the carious areas or the diseased tissue. So we have to remove the diseased tissue. Okay. And what we will do in turn after that, we'll be restoring the integrity, the function, as well as the appearance of the tooth. Okay. So disease tissue in this regard, like you should be knowing with regard to the concept of affected and infected dentin. Okay. So can anybody tell me what dentin will be removing? Whether is it the affected dentin which you will be removing, or the infected dentin? Anyone? You already learned these things. Are you there, guys? Anyone? Which is the dentin which you will be removing? Infected or affected? Yeah, tell me, Bashar. Which one will be removing? Infected or affected? See, one of the objective is to remove the diseased tissue, right? Nobody. Uh, no, actually, okay. We will be actually removing the infected dentin, okay, not the affected dentin, okay. So basically, it's your infected dentin which is actually soft in texture. It has a leathery texture to it. It is brown in color, and it is actually invaded by the microorganism. Whereas your affective dentin, we will actually not touch it. Okay, we'll actually allow it there so that we can actually initiate the formation of reparative dentin. Okay, so usually while you are using your spoon excavator, when you are actually excavating the soft caries is your infected dentin, which we are actually removing while the cavity preparation is being done. Okay, so again, we'll be discussing this concept when you're actually dealing with ART. Okay, just for your knowledge purpose, I just shared this information. So, what determines the cavity design? The structure and properties of the dental tissues, the diseases, the properties of the restorative materials. We already touched upon this in the last lecture. So, basically, what is the remaining tooth structure? Okay, so depending on how big a cavity is, we will actually decide what type of restorative material which we will have to give. Okay, so if at all there is a primary tooth, I told about the drawbacks of using amalgam as a restorative material in a primary dentition, because it usually requires an extensive preparation. Okay, so where if at all it is a small pit, say for example it's a small pit, okay, there are decay, it's a small pit, then the recommended material would be not an amalgam, because it requires an extensive prep. We will go for something very convenient like GIC or a composite restoration. Okay, how deep the disease is? If the disease is very deep, then we will actually modify our preparation. We will go for we will prepare the cavity keeping in mind for a pulp capping procedure. Okay, so what is pulp capping? Again, you will be learning in your coming lectures. Okay, so I'm just telling, depend on the disease process as well, and the properties of restorative materials which we are actually having. So here the advantage of using materials like GIC and composite is very convenient, because we need not follow the GV Black's preparation, which again emphasizes extensive preparation. Okay, so we will go for materials like GIC which are more adhesive or has chemical bonding with two structures. Okay, so these are the things which will actually determine the cavity design. But for instance, we want to give a gold prep, gold restorative material, or a amalgam as a restorative materials. It all these materials gives us maximum strength. Okay, gold gives us maximum strength, amalgam gives us maximum strength. So when we are actually planning for such restorative materials, we will have to prepare accordingly. Okay, depending on the property of the restorative materials, also our cavity design will change. Okay, so so far any doubts, guys? Anything which you want me to repeat? Anything which you want me to repeat in previous slides? Everything is clear? Okay. So now coming to the yeah, okay. So now coming to the caries process and surface involved. So we know, like, basically in pediatric dental clinic, when you see patient, no, most of the time you will be dealing with primary dentition. Okay, and again this can be actually divided into three phases. Very rarely do you get patients who are in the infancy phase. Okay, mostly there might be some kind of underlying emergency which will actually like, what do you say, force the parent to come to the clinic. Okay, other than that you will rarely find, especially in our sessions, you will rarely find patients aged from 0 to 2 years. Okay, usually there might be some kind of natal or neonatal teeth which is actually causing a problem with feeding, or might be due to some kind of traumatic injury. The parents are forced to bring the child at such a young age. Okay, so rarely do you see patients coming in the infancy period, that is 0 to 2 years. Usually you'll be dealing with primary dentition as well as mixed dentition, and you know the age group. Okay, by 2.5 3 years of age, all the primary tooth will be erupted, and from 3 to 6 years of age, you will be having mostly only primary tooth in the oral cavity of the patient. Okay, and sometimes there might be early eruption by 5.5 years and all. You might see a permanent molar erupting, but usually it is 6 years when you have the first permanent molar which is being erupted into the oral cavity, or the first permanent tooth erupting. And it can be sometimes the mandibular permanent central incisors as well. Okay, at 6 years of age. So usually by 6 years you will have your mixed dentition period starting. Okay, and this will be anywhere between 12 to 13 years of age, it will extend. And by 12 to 13 years of age, all your primary tooth will shed off. Okay, then only permanent tooth will be moujud in the oral cavity. Okay, so this is the time frame which you have to keep in mind. And when you are actually dealing with pediatric patient, you should know what all tooth, or you should anticipate what all tooth can be present in the oral cavity. Okay, So at times you might find it difficult to differentiate premolar from a primary molar. Okay, so you can use this formula, like what is the age of the patient. So if the patient is 6 years, you know that it is a primary molar, because premolars don't erupt at that particular time period. Okay, and the caries which is seen previously, like it was different names was given, like nursing caries, because usually this caries was seen with children who were actually feeding bottle. Okay, or it was also known as nursing bottle caries or rampant caries. So nursing bottle caries, why? Because the biggest culprit is your the milk, which is actually acting as a carbohydrate substrate. And usually the children will feed the bottle in the night, and they don't clean their mouth. Okay, because they'll be feeding the bottle and they'll be actually sleeping like that, just like that. Okay, so what happens, there is a high activity of bacteria, because the salivary flow while sleeping is very less. Okay, so saliva doesn't act as a buffer at that period of time, and there is a substrate which is in constant contact with the tooth. And as a result, the nursing bottle in the feeding in the night, especially in the night, was one of the major reasons, okay, for caries. So it was called as nursing bottle caries in olden times. Okay, but now we know it is not just nursing bottle, it is a collaboration of different factors. It can be nursing bottle, it can be environmental factors. Okay, other environmental factors, the diet, the oral hygiene habits of the child, all these things will contribute. And now it is termed as ECC. Okay, ECC, I'll just type it in the chat box. It is also called as early childhood caries. Okay, so we use this term now. Okay, very important, very important with respect to pediatric dentistry. You should know this term, early childhood caries. Okay, I just typed it in the chat box. Okay, ECC or early childhood caries. Now coming to like the where you can see the dental caries in the primary tooth or the anatomical sites. Okay, so when we speak about the second molar, maxillary and mandibular, you will see it in the occlusal as well as the lingual areas. Okay, so occlusal and lingual pit in the maxillary, and mandibular it will be occlusal and buccal. Okay, so occlusal aspect and the buccal aspect you will find decay, and maxillary you will find it in the occlusal and the lingual pit. Okay, in the second primary molar. Coming to first molar, you will see it in the occlusal aspect, and mandibular you will find caries process most commonly occurring in the occlusal and buccal. Canine again in the buccal aspect. Lateral incisors and central incisors you will find it in the both the maxillary and mandibular. You will find it in the mesial aspect. Okay, these are the common areas where caries happen. Okay, and it is not just it is not a rule that only there you will be finding caries, but these are the common areas where you will be finding caries. Okay, coming to the mixed dentition, 6 to 12 years of age, as I already told you, permanent molars are in and incisors are most affected, because they are susceptible for plaque retention. Okay, so here again, occlusal surface of permanent molars, the lingual development pit and groove in the maxillary permanent molar, the buccal development pit and groove in the mandibular permanent molar, the lingual development pit in the maxillary incisors, especially your lateral incisors, and mesial surface of permanent molars are at risk in developing proximal lesions. Okay, so these are the areas where there can be most activity of the caries process. Okay, now coming to the factors to be considered before restoring the tooth. Okay, especially with primary tooth, you should, as I told you, you should keep the age of the child in your mind. Okay, sometimes if the tooth is nearing exfoliation, there is no point giving a very elaborate restoration on that particular tooth. Okay, so you have to keep in mind, say the patient is 12 or 13 years of age, and second primary molar has a occlusal pit. So don't take the a headache of actually preparing a big class 1 cavity and restoring the tooth, because the tooth might be nearing exfoliation. So age of the child is always a factor when we are actually planning for a pedo restoration. Okay, degree of the caries involved. Okay, you should keep that in mind as well. Most of the time, especially if you had attended the practical session last week, I think for the girls as well as the boys, we had told you the thickness of the enamel and dentin is very less compared to that of your permanent tooth. And 1 mm cavity will be very close to the pulp, so you might have to rethink your treatment plan. So the tooth might go for some kind of pulp procedure like a pulp capping or a pulpotomy. Okay, based on the extension of caries. So degree of caries involvement is a very important factor to be considered as well. The condition of the tooth and supporting bone in the radiograph, just like your adult, we have to see the condition of the tooth, whether not only the enamel dentin, even the supporting structures, the periodontal structures, as well as your cementum and or the alveolar bone, the condition of the bone, everything is actually sound. Okay, this we can determine with the help of your radiograph. Okay, the time of normal exfoliation, the same thing, the age of the child and the time of the normal exfoliation is the same factor. You should know when the tooth is going to shed off. That is a very important criteria. Then the effect of removal or retention on the child's health. Okay, so if at all we are extracting the tooth, will it affect the child's health? Okay, child's health can be both physiological as well as psychological. Okay, so child's health, if the tooth is removed, the child will have a difficulty in what? The child will have difficulty in mastication. Okay, so the nutritional intake can get compromised. Okay, so this will affect his physical health. Okay, and at the same time, say for example, an anterior tooth is extracted. Okay, okay, and or you are planning to extract an anterior tooth, and this can have an impact on the child's aesthetics. Okay, this can affect the child's psychology. Okay, so that will also be affected at times. Okay, so that also needs to be considered. And space consideration in the arch, whether removing a primary tooth or restoring will be of benefit. Okay, so if you are removing, sometimes if there is a severe crowding, actually you can take an orthodontic point of view and actually go for an extraction. But sometimes an early extraction of a primary tooth can lead to space loss in future. Okay, there can be mesial and distal migration of the adjacent tooth to the like the irregular space. Okay, so that also has to be considered at times. Okay, now, as it is similar. Okay, a need is similar to the rationale of preservation of primary tooth. We already spoke about it. Maintenance of the arch length. So, when you actually extract a tooth rather than restoring the tooth, what will happen is there can be this migration of the adjacent tooth to this space, and the permanent successor, which was supposed to erupt into that rectangular space, can get compromised. Okay, so while restoring will actually maintain the arch length. Okay, so usually you get this question, like the parents will come to you and tell that, doctor, it's a primary tooth, just do extraction for this tooth, because the permanent tooth will come. That time you will have to emphasize on this point. Okay, because the, say for example, you are extracting a second primary molar at the age of 5 years or 6 years. Okay, second primary molar is extracted, you know the second premolar will erupt only by 10 or 11 or 9 years of age. Okay, depending on whether it is mandibular or maxillary arch, it will erupt only after 4 to 5 years. So 4 to 5 years is a big time for an edentular space. Okay, what will happen? There will be edentular space, it will affect the masticate, there will be excess masticatory load on the remaining tooth. One thing, which can cause damage to those teeth. And second thing, these tooth, the adjacent tooth can actually migrate into the edentular space, causing either impaction of the permanent successor which is supposed to erupt, or it can cause ectopic eruption. The tooth can either erupt buccally or lingually, causing orthodontic issues. Okay, so this you have to actually keep in mind. Then maintenance of healthy oral environment. So if you are actually if you have all the tooth and if you give a proper restoration, there is less of what do you say, bacterial load. Okay, so a healthy oral environment is actually preserved, and it prevents the pain and gives relief to the patient. Okay, then it maintains and improves the appearance. Okay, so there is psychological well-being as well, as I told you before. Okay, if there is no teeth present, the child is in a growing phase, his friends might make fun of him, this can affect his psychology. Okay, so it will actually improve the aesthetics and have a positive impact on the child psychology. Okay, then it will help in the function of chewing, it will obviously help in the function of chewing and nutritional intake and mastication and speech as well. This is again important point. Example, like the child is learning to speak, right? In a growing phase, the child is not only learning to brush, to walk, he is actually learning to speak as well. When he goes to school, he learns different languages, he learns to communicate with his friends, with his teachers. So while speaking, no, like if I'm talking in terms of English alphabets, vowels, I hope all of you know what vowels are. A, E, I, O, U is your vowels. So other than vowels, the consonants, that is other alphabets like B, C, D, E, all these sorry, E is a vowel, B, C, D, F, all these things, no, it's actually consonants. So consonants, usually the individual will take the help of the tip of the tongue, and the anterior teeth is usually used to pronounce the consonants. Okay, so if anterior teeth is not there, usually you extract the anterior tooth due to early childhood caries, then the child will not develop proper phonetics or speech. Okay, there can be lisping sound, so speech is not properly developed. So tooth plays a vital role in developing speech as well. That you have to keep in mind. So when you're actually trying to convince the parents, you should tell regarding this also. Okay. Then again, undergoing the trauma of the tooth extraction. So usually when in pedo clinic we say that we have to put the extraction as the last procedure which you are doing, because this can have a negative impact on child with regard to coming to the dentist. Okay. So if in the first visit itself you are actually doing a tooth extraction, then the child will have this phobia for dental treatment throughout his life. Even when he becomes an adult, he'll fear the dentist. Okay. So tooth extraction, try to avoid and keep it as a last treatment. Only if it is absolutely necessary we'll do extraction. Okay. So these are the rationale for why we are actually preserving the primary tooth. Okay. Now coming to the anatomic consideration of primary and permanent tooth. Okay, so you should know. I think the same topic was already discussed in your what do you say, a preclinical session, but still I am repeating. Okay, so you know there are anatomical differences when we speak about primary as well as permanent tooth. Okay, so the let me go to the next slide. Yeah, as you all know, the major difference is the tooth. Primary tooth is smaller when you compare with that of your enamel. Okay, so you know the crown and root is shorter when you compare with that of your permanent tooth. It has a narrow occlusal table when you compare it with that of your permanent tooth. Occlusal table means your occlusal surface where you have your pits and fissures and grooves, cusps, everything. Okay, so basically there is the area where you are actually preparing your class 1 cavity, that is your occlusal table. So in your primary tooth you have a very small or a narrow occlusal table. This is one of the reason why we don't prefer giving amalgam restorations in primary tooth. Okay, because amalgam requires extensive cutting, and you will have to remove almost like 70% of the tooth structure, or structures which are actually giving strength to the tooth. Okay, so narrow occlusal table, it has a constriction in your cervical portion. Okay, it is like a bulb, it is bulbous in nature, it has a cervical constriction. Thinner enamel and dentine layers. So all of you know, when you're actually preparing your class 1 permanent cavity, you know the initial depth is 1 to 1.5 mm you're actually giving, right? Your initial depth. But if you do that in your primary tooth, you will invariably expose the pulp. Okay, so thinner enamel and dentine layers has to be kept in mind. Okay, so don't prepare a cavity like your permanent tooth when you're actually preparing for your primary tooth. Okay, then very important point, students, please highlight this if you can. Enamel rods in the cervical area is directed occlusally. Okay, so there is a difference in the direction of the enamel rods. This is usually asked as an MCQ question. So because of this, when you're actually preparing your class 2, okay, usually when you prepare your class 2 in your permanent tooth, you give enamel bevel, right? Because the enamel rods are actually directed gingivally in your what do you say, permanent tooth, you give an enamel bevel. Here, because the enamel rods in the cervical area is directed occlusally, you don't give an enamel bevel. Okay, you don't do a enamel beveling in your class 2 prep. Very important point, you should know the direction of the enamel rods. Here the enamel rods are directed occlusally, whereas in your permanent it is directed gingivally, and there you give a enamel bevel, but in your primary tooth you don't do enamel beveling. Okay, hope you understood. Okay, again, broad and flat contacts, but you have narrow and point contacts in your permanent tooth. Here you have broad and flat contacts, and color is usually lighter. And they say the refractive index of this primary tooth is similar to that of milk. Okay, so that's why it is called as milk tooth, and it is lighter in color. Okay, any doubts, guys? Any doubts? Very important slide. Any one of the difference can be asked. Please ask if you have any doubts. You want me to repeat any point? Please, are you guys there? Okay. Crown and root. Okay, so like there's a prominent mesobuccal cervical bulge which is seen. They're very clear in this picture. You can see a mesobuccal bulge with respect to your primary molars. Your maxillary molars here is shown. You can see a cervical bulge. Usually, this bulge will give retention for stainless steel crowns. If you remember, last week we had discussed regarding stainless steel crowns. This bulge gives the retention for your stainless steel crown. That's why we say that you are not supposed to touch the buccal as well as the lingual aspect. Only we do preparation in the proximal, right? Because the cervical bulge need not be compromised when you're actually doing preparation, because this cervical bulge gives retention for your crown. Okay, that's why we say only occlusal and proximal preparation in your stainless steel crown. Okay, and incisors have no development grooves or mamelons, so this will help you differentiate between your permanent tooth from your primary tooth. Okay, coming to pulp, it is relatively larger when you compare to the enamel dentin pulp ratio. Okay, don't think that the pulp is relatively larger means there is a large pulp chamber. Primary tooth pulp chamber is large when you compare with that of permanent. No, it is not like that. Relatively, it is larger when compared to the enamel and dentin thickness. That is what is meant here. If you remember the first slide, enamel and dentin thickness is very less, no, in primary tooth. So compared to that enamel and dentin thickness, we have a relatively larger pulp horn. So this is the point which you have to keep in mind. Okay, and it's not that the pulp horn, sorry, the pulp chamber is larger when you compare with that if you have permanent. Not like that. Compared to the enamel and dentin thickness of primary tooth, the pulp is larger. Okay, pulp horns are closer to the outer surface because of the thin thickness of enamel and dentin. Greater variation in size and location. Mesial pulp horn is highly placed. Okay, so especially if you get a mesial proximal lesion, don't go for a class 2 because invariably the pulp might be exposed. Okay, as the mesial pulp horn is highly placed. Again, a very important MCQ question. Please make a note of it. Okay, and pulp chamber is shallow. A form of pulp follows the external anatomy. So these last 2 points are interrelated. The form of the pulp follows the external anatomy, and usually a pulp horn is seen under each cusp. Okay, so since the outline is closely followed, you can predict that there will be a pulp horn under one cusp. Okay, so it actually helps you when you are actually preparing a access preparation, especially when you are actually doing a what is a root canal procedure for primary tooth, like a pulpotomy or a pulpectomy. It will be very easy because invariably there will be a pulp horn just under the what is a cusp, and it will be easier for you to determine the access prep. Okay, so it's the same thing. Need for restoration of deciduous teeth. We already discussed this. When there is a caries lesion, when there is a fracture, when aesthetics is of primary concern. Okay, when we want to actually preserve the tooth structure and protect the interproximal surfaces and protection of occlusal surface. All these things we already discussed. Okay, so I'm just rushing through. Okay, anything which you want me to repeat in this? I think it's already discussed. If at all, if you have anything, please type it in the chat box. Okay. So the class 1 to class 6, it is similar to your permanent tooth. GV Black's preparation is similar to that in primary as well as your permanent. You know what a class 1 is: pit and fissure cavities in the occlusal surface in your posterior teeth, and the lingual surface in your anterior teeth. Class 2, proximal surface of posterior teeth. Class 3, proximal surface of anterior teeth without the involvement of incisal angle. Class 4, with the involvement of incisal angle. Class 5, cavities in the gingival third. Class 6, cavities on the incisal edges of anterior teeth and cusp tip of posterior teeth. I am sure all of you know all these things by now. It is the same thing. Okay. Now coming to principles of cavity tooth preparation. It's the same thing. Again, same thing. Initial step 1, it's the outline form. Outline form is the form of the cavity walls which will occupy in the final preparation, right? So there is an internal outline form which is actually referring to the internal perimeter of the cavity or the internal details of the cavity, and external outline form which actually determines with the external perimeter of the cavity. Okay, so outline form, it is the form of the cavity walls which will occupy in the final preparation. What is primary resistance form? Somebody please tell me what is resistance form, just to make sure that you guys are not sleeping. What is resistance form? Please guys, somebody, resistance form. No one. You have learned this, right? Primary resistance form, primary retention form, convenience form. Guys, there. Okay, I will tell one form. You have to tell me whether it is resistance form or retention form. Okay, so the form which act. Okay, resistance form is not preventing movement here. It's actually retention form. Okay, so resistance form is a form which enables the tooth as well as the restoration to withstand without fracture forces delivered principally along the masticatory forces delivered principally along the long edge of the tooth. So resistance form is actually dealing with resisting of fracture. Okay, fracture of the tooth as well as the restoration. Okay, so resistance form, remember, it is with regard to your fracture. Okay, we from what? From your masticatory force, which is actually delivered principally along the long axis of the tooth. So examples of resistance form include your flat pulpal flows, okay, relatively flat pulpal flows, rounding of the internal line angles. You remember all these things: rounding of the internal line angles, inclusion of all the weakened enamel structures. Okay, all these things are actually what? Your resistance form. Okay, retention form is actually preventing movement. Okay, so it is basically the form which prevents the displacement of what? Displacement or movement of the restoration, displacement of the restoration from tipping or lifting forces. That is retention form. So your examples of your retention form is dovetail is an example of retention form. Then occlusally converging cavity walls, occlusal convergence of the cavity walls is another examples of retention form. Okay, your pin slot preparation, all these things are examples of your retention form. Okay, convenience form, coming to convenience form, it deals with your observability, accessibility, and ease of preparation when you're actually trying to do a preparation and giving a restoration. Okay, it deals with your observability, accessibility, and ease of preparation. Okay, basically making your preparation and restoration much easier. That is convenience, or improve your convenience. Okay, then after that, removal of caries dentin. We'll do removal of caries dentin. Do pulp protection. We already discussed regarding pulp protection. How will you do examples of pulp protection? It's like you can give a liner or a base. We already discussed the last class. Okay. Then finishing external walls, cleaning and inspecting, and sealing. Okay. So what are the instruments used for cavity preparation? Spoon excavator, as I told you, to remove carious dentin. So which dentin will remove? Infected or affected dentin? Which dentin will remove using spoon excavator? It is used from periphery to center to remove carious dentin. Which dentin is removed? Infected or affected? Infected. Very good. Okay. So infected dentin is removed. So infected dentin is removed. Affected dentin will be not touched. Okay. It will be retained. So affected dentin will not be removed. Infected dentin will be removed. Okay. Just remember this in mind. Enamel hatchet. To remove the outer enamel wall in class 2 preparation, we use enamel hatchet or remove the unsupported enamel from the buccal and lingual walls to round off the axiopulpal line angle. Okay. All these things we actually use the enamel hatchet. Gingival marginal trimmer we hardly use in primary tooth cavity preparation. It is also used for beveling the cavo surface margin. Okay. So again, the same thing, gain access to the caries. Okay, remove all the caries. Design of the cavity should be before determined by the final choice of material. So if you are giving an amalgam, you require an extensive preparation. If you are giving a GIC, not so much. GIC and composite, not so much. Okay. Then again, retention of the restoration should be kept in mind. Protection of remaining tooth structure, optimal strength of restorations, and protection of cavity margins. Once we do that, then refine and debride, then place the restoration. Okay, so design of the cavity again, where I think Dr. Tasneem in the females college and myself and Dr. Zakir have already discussed this thing. You are not supposed to touch the oblique ridge as well as the transverse ridge in your molars. Okay, because the oblique ridge as well as your transverse ridge gives maximum strength to the tooth structure. So that is what is meant by protection of remaining tooth structure. You don't touch your cusp. Okay, your class 6 GV Black's cavity classification is very rare, right? So unless and until there is a cavity in your cusp or your ridges, no, you don't actually involve them in your cavity preparation. Okay, oblique ridge, transverse ridge, your cusps and all, you don't involve unless and until there is a need to do so. Okay. So cavity preparation class 1 amalgam. So before going to this, I want to tell you, see this amalgam, all these features you are learning just for theoretical purpose. Nowadays, you have to keep in mind that for pedo, we don't use silver amalgam anymore. Okay. So you might ask me why you are learning these things. It is just for your exams. Okay. Because we have beautiful materials, different form types of GIC, which we discussed last time, different types of composites. Okay, even there are JC which has which in which silver particles are incorporated. Okay, like cermet cement and all, which gives beautiful results. Okay, so we don't actually use amalgam anymore in like pedo. One, because it requires extensive preparation, and invariably when we try to give all the features, the pulp will get exposed. Second feature is second is due to the mercury toxicity of amalgam. Okay, we don't use amalgam anymore, but you are learning this just for academic purpose. Okay, because this is the basic. And amalgam is a time tested material. At least in permanent tooth, it still has a role to play because it gives maximum strength and longevity. Okay, no material has come even close to it with when we compare to the strength of the material. Okay, so at least for the permanent tooth we still use amalgam, but for primary tooth you are learning just for academic purpose. Okay, so what are the features in your cavity preparation? Class 1 amalgam in your external outline form, dovetail, inclusion of pits and fissures and grooves and caries. It's similar to a permanent tooth. Okay, extension of occlusal portion. It varies depending on which primary molars which is involved. Okay, so basically, if the maxillary molar or mandibular molar, it varies. Okay, occlusal convergence. So when you give slight occlusal convergence, you automatically get cavo surface angle of 90 degree, right? I think I have a picture that time I'll explain this thing. Sharp cavo surface margins, okay, of right angles. Adequate tooth structure of the marginal ridges should be there. Okay, again, ridges should not be involved unless and until it is absolutely necessary. Especially try to avoid the oblique and the transverse ridges. Width of the preparation should be one third of the occlusal table, or the isthmus should be one third of the occlusal table, and rounded line angles. Okay, to avoid stress concentration. Now coming to internal outline form, penetrate approximately 0.2 mm into the dentin. Round line angles, provide the burrs kept somewhat vertical. Pulp floor is slightly concave and all internal line angles should be rounded. Establish a sharp cavo surface angle. Again, as I told you, 90 degrees. So when you give occlusal convergence, you will automatically get a sharp cavo surface angle. The walls are parallel or slightly undercut to the external surface of the tooth. It's the same thing, again repeated. See, here you can see the occlusal convergence and automatically this A alphabet, right? There is the cavo surface angle and you are getting a 90 degree. I hope you can understand. You already know what it is. Okay, again, you can see the purple floor. It is slightly concave or it is straight. Okay, you can give say, slightly concave or it is straight, and there is sufficient distance from the pulp. So this is how you should be giving it. Okay, you understood the concept of sharp cavo surface angle, guys? Please respond. It's a big lecture. I'm trying to finish it before time. Please respond. You understood the concept of cavo surface angle, right? Okay. So cavity preparations in primary tooth are modified to accommodate the tooth size, pulp size, enamel or dentin thickness. Already discussed. Okay, you have to keep all these things in mind. Thin enamel and dentin thickness, larger pulp, like a larger pulp area, and pulp horns are highly placed. All these things should be kept in mind. Outline should be dovetailed, including all fissures, area of caries, pits, and developmental grooves. Occlusal convergence, flat pulpal floor. Again, the same thing is being repeated because this is very important. Cavo surface margin should be sharp, rounded line and point angles. Okay, coming to class 2. Again, class 2, if you have a class 2 primary molar. Okay, if you have a class 2 in a primary molar, say for example both the aspect, mesial and distal aspect is involved in your clinics, please don't give a MOD. You don't go for an MOD. You will give what? You will give a stainless steel crown. Again, you are learning this just for academic purpose. Okay, so you'll tell doctor, why are we learning? Because this is the basic. You guys should be knowing this. That's why we are learning this. But if at all a clinical scenario comes in your clinic or in your private practice, when in future you are going to become busy practitioners, don't go for an extensive preparation. It is a headache. If you go, say for example, an MOD scenario is there. Okay, MOD scenario is there. Invariably, you will expose either the mesial pulp horn or the distal pulp horn. It will be exposed for sure in primary tooth. And if even if you give, even if GE Black comes and gives a restoration, also the restoration won't stay in a primary tooth for more than 6 months to 1 year. That is lazim. So it is going to fracture. The restoration is because of the anatomy of the primary tooth. It is not because of the inefficiency of the dentist. Because of the anatomy of the primary tooth is as such, we don't go for such extensive preparation nowadays. We go for a stainless steel crown. Okay, keep this in mind. Stainless steel crown. Okay, MOD. So how do you do class 2? Complete class 1 cavity first. Okay, extend the occlusal outline to the marginal ridge. Keep the burr parallel to the long axis of the tooth. Sweep the burr buccally and lingually in a pendulum motion and in a gingival direction. So basically, these are things which you are actually doing. Okay, when we actually put it in words, it might sound very technical, but these are things which you actually do. Like it is similar to what you do in a permanent tooth when you're actually preparing a class 2. Break all the contact gingivally. Check with the explorer. Axial wall should follow external contour, and depth is determined by the caries depth. So you will have to extend till the caries is there, right? That's the whole idea. The initial objective is to remove all the caries, right? Width of the isthmus is one third of the occlusal table, that you already know. Proximal box is widest at the gingival margin. The axiopulpal line angle should be avoided. All the line angles should be rounded to avoid stress concentration. No bevel. This is the important point. Okay, all these points are similar except this point. No bevel is given at the gingival margins. Why? Can anybody tell me fast? I already told. Why bevel is not given? This is the most important point in the slide, guys. This will definitely come for your MCQ. That's why I'm asking. Why bevel is not given at the gingival margins? Very good. Okay. Enamel rods, knife correct. So the direction of the enamel rods is different. Okay. It is directed occlusally in your primary tooth. So there is no unsupported enamel rods there when you're actually preparing your class 2. Whereas in your permanent tooth, it is directed gingivally. That time you will have to give an enamel rods. Here, the direction of the enamel rods is occlusal. That's why you don't give gingival bevel. Okay. No secondary retention features is required in primary tooth cavity preparation. That's another feature. Okay. Transverse and marginal ridges, these should be at least 1 mm in width. Okay. So see, this transverse ridge, marginal ridge, oblique ridge should be left behind. It should have a sufficient thickness, at least 1 mm should be there for the tooth, because these are the structures in the tooth or the landmarks in the tooth which will give maximum strength to the tooth, or which will resist maximum masticatory forces. Okay. And depth from the outer enamel surface should be 1 mm from the KO surface angle. See, this is, see, so 1 mm from the KO surface angle. So ideally, the depth should be at least not like 1.5 mm to 2 mm, maximum 1 mm only. Okay, this is another difference. Okay. So see this picture again, the same picture is seen. KO surface occlusal convergence, KO surface angle 90 degree, rounded axiopulpal line angle, inverse taper of the proximal box, and see gingival seat. The mesial pulp horn is very highly placed. Okay, so you have to provide sufficient clearance. Okay, so all these pictures are actually self-explanatory. Okay, which will help you understand the concept much better. Again, these pictures, okay, shows different types of preparation. Okay, palatal extension, your class 2. Okay, how the occlusal convergence should be there. Okay, inverse taper of your proximal box. Very good picture, you can understand it much better. So that was with regard to the principles or the modifications which we have to do with regard to your primary tooth cavity preparation. The properties of restorative materials, we already discussed restorative materials, but still, okay. So coming to the properties of restorative materials, it should be, as you know, like we don't use amalgam anymore. We incline more towards GIC, your composites, okay, your resin modified GICs, and your, what do you say, crowns, different types of crowns. Okay, so material should be easy to use. It should be tooth colored. Okay, easy to use. Amalgam is not very easy to use. Again, tooth colored. Amalgam is not a tooth colored material. It is not an adhesive, whereas GAC is. No change of volumetric shrinkage should not be there. Okay, so this is also an important point. It should not uh, undergo volumetric shrinkage, whereas in your amalgam there can be delayed expansion in 1 to 7 days. If at all there's some kind of moisture being entrapped, it should provide protection. This is the only advocate strength. That is the only advantage of amalgam actually. Okay, it should be insoluble and non-corrodable. It should not undergo corrosion. It should be non-toxic. Amalgam is a non-toxic. It's a toxic material. Okay, mercury toxicity is one of the major concerns now. It should be easy to trim and polish. It should resist the formation of dental plaque. Rate of wear should be similar to that of enamel. Okay, and coefficient of thermal expansion should be similar to that of enamel and dentin. So coefficient of thermal expansion is nothing but the change of a material when it undergoes the temperature change of a material when it is exposed to heat. Okay, that is coefficient of thermal expansion. So you know, when any material is exposed to heat, it undergoes an expansion. So that should be similar to that of enamel and dentin. So the material you should have a similar coefficient of thermal expansion to that of an enamel and dentin to be compatible with that the oral environment. Okay, thermal diffusivity, it is the transfer of heat or diffusion of heat through the object. So it also should be similar to that of enamel and dentin. Okay, so thermal diffusivity similar to that of enamel and dentin. Low water absorption, it should not absorb water. radio opaque, the material should be radio opaque so as to we can appreciate in the radiograph. Okay, if it is radiolucent, it is very difficult. Okay, so usually these materials, for example, materials like calcium hydroxide and all, barium sulfate is added as a, it is a radiolucent, mostly radiolucent calcium hydroxide. So we add radio opacifiers like barium sulfate to make it more visible in the radiograph. Okay, and it should have good shelf life, and the material should be inexpensive. So these are the properties which a material should be having. And various restorative materials we already discussed, like which you can use in pediatric dentistry. Amalgam not used, it was previously used, but GIC, resin modified GIC, composite resin. Okay, then your different types of crowns like stainless steel crowns, strip crowns, etc. And nowadays we have new smile crowns, which is actually an excellent material. Okay, for your restoring the primary molars as well as your anterior teeth. Okay, it is based on zirconia, so that is also a newly available material. So these are different materials which are actually available right now. So hope you guys understood the lecture. Any doubts, please ask me now. Okay.